thank you. I think, again, we'll have a panel discussion, because I think some of these themes will probably be common across the different speakers, so we'll put all those together at the end. The question is actually whether actually that whole talk was written by kind of AI. I know it's what most students do these days.
Our next speaker is Dr. Tim Bray. He's a consultant radiologist and an MRI researcher between the Centre of Medical Imaging, University College London, and the Imaging Department at UCLH.
Thanks. So I'm going to present a particular perspective on imaging, which is mostly MRI focused, but set against the backdrop of what's been happening in imaging generally in recent years. So in the last few decades, we've seen really dramatic advances in MRI technology. So the Nobel Prize for MRI was actually won in the early 2000s, but since then we've seen really quite profound acceleration of scans. We've seen new ways of getting image contrast and getting new biological information from images. And we've also seen a new class of methods called quantitative MRI, whereby we can actually isolate specific tissue properties much more precisely than we were able to do before, and also overlap different processes that might be present in the tissue. And together with this, we've seen, especially in very recent years, a real revolution in deep learning technology, with Geoffrey Hinton recently winning the Nobel Prize. And this is increasingly being applied to imaging. We've seen a huge explosion in the use of deep learning in radiology, and there's a whole range of new journals, new infrastructure, which have popped up in an attempt to kind of cope with this radiology AI revolution. But what might be less obvious is how these advances can actually improve imaging for real patients. So I'm going to focus on three main aspects in this talk. I'm going to talk about how we can characterize the tissue better, how we can image faster and more efficiently, and how we can achieve more consistent image interpretation. So the first question is, how can we characterize the tissue better? Well, to answer this question, we need to first understand what the problems are with our existing methods, and as I said, I'll use MRI to really illustrate this. Well, one of the problems we have with conventional MRI is that the signal we get is really an aggregate from lots of different processes that are happening in the tissue all at the same time. So we can think of the tissue as being like a soup, and there's all these different properties that we might be interested in measuring, T2, T1, these are all things we can measure with MRI, but usually we're only interested in actually measuring one of these properties, and this is the target. So maybe T2 is what we want to know about the tissue. But if we take a spoonful of this soup, what we're actually getting is a mixture with all this other stuff mixed up together. And we don't actually know what's gone into this soup. We can kind of see how it tastes, but we have really no idea how it was made in the first place. So this is a problem when you're trying to get towards a very specific interrogation of the tissue. And this is also very apparent when you think about the bone marrow. You can see it's a very complex tissue, far more complex than I can understand as a radiologist, and there are all these different cell types, structures present, even in one imaging voxel. But if we think carefully about this, we might see that actually there are some differences between the elements of the tissue that we could begin to interrogate with MRI. So for example, we know there are lots of cells containing fat, these are adipose cells, and these do have quite different MRI properties to the other parts of the tissue. So the cells in the extracellular space, which we might really crudely think of just as a water compartment, have different properties again. And then we've got a sort of trabecular compartment, which does a very different thing to the MRI signal to those first two compartments. So this kind of gives us a clue that actually maybe we can do better, maybe we will be able to strip these different compartments apart. And this class of methods that I referred to, known as quantitative MRI, actually allows us to do this. We've got a whole range of different methods, diffusion, Dixon, relaxometry, etc. There are hundreds of these things now. But the unifying idea is that we can separate these compartments, we can measure how big they are, and so we can actually measure the size of these compartments as a fraction of the whole, and we can also get towards actually measuring these properties which are specific to each compartment, free from the confounding effect of those other compartments. And if we think about the disease processes that might actually affect the tissue, it becomes apparent that if we can do this, we can actually capture a lot of different processes in quite an efficient way. So if we think about malignant infiltration, for example, You can see on this slide here, well, we've got more cells. Of course, these are cancer cells, and they're also going to have different properties. So we're going to see an expansion in that water compartment, and we're going to see that the water compartment also has different properties. If we think about osteoporosis, which is often there in the background in our myeloma patients, or sometimes as a facet of the disease itself, we can see that there's going to be more fat, less cells, and less of the trabecular compartment. And we may also have combinations of these processes overlapping. So we might have malignant infiltration as well as lysis, for example. And we may have quite complex lesions as well, where maybe we've got a partially treated lesion, we've got some fat, we've got changes in the bone compartment, and we may have actually a very relatively small number of malignant cells. And this makes it especially important to be able to separate these compartments. And just thinking about this overall, we can think of this there being a sort of set of axes along which we can characterize the tissue in an efficient way. We can have a sort of cellularity or packing axis, which tells us how many cancer cells there might be in the tissue. We can have a fat axis, which tells us how many fat cells there are, and another axis, which tells us what's going on with that bone compartment. And we've also already got some pretty good clues that this is really going to be a useful way of thinking about the tissue. So we know, for example, that fat fraction measurements allow us to differentiate between malignant and benign lesions, and that includes myeloma lesions pretty well, and actually better than diffusion imaging, which is very commonly used for this, and we're using this increasingly in our clinical practice. It allows us to discriminate between responding and non-responding tissue and get towards a much more lesion-specific assessment of what's going on in a patient. And we're also all the time learning to refine these techniques. This is some nice work from Jess Winfield's group at the Marsden, which shows the performance of different techniques in measuring the fat fraction in myeloma lesions. And actually, you can see there are some quite big differences, and these are potentially important and reflect the ability of these different methods to actually separate these different processes. So we're learning to do better at actually isolating individual features of the tissue. And coming back to the idea about overlapping processes, this is some work that we've done at UCL, which uses a method, a QMRI method, which actually simultaneously can quantify what's going on in two different compartments. It can measure how much water and fat is present in the tissue, but also give us a measure of the T2 that's present in that water compartment. And we've already got some early indications that actually you can see different features in the bone marrow that you can with conventional MRI. So we're starting to see kind of hidden pathology, which is just not visible with our standard imaging. And talking about things which are normally seen as invisible, it's often said that you can't really see bone with MRI and you need CT to do that, but actually it's not true. And there are some pretty widely available methods now, such as R2 star mapping and susceptibility mapping, which allow us to actually get pretty direct information about how much bone density is in the tissue. And I think this has a very obvious application to myeloma, where we're interested in lysis and fractures and so on. So I think in the years to come, we're going to see this filtering through into the mainstream, and these methods are just going to get better and better, and maybe we won't need ionizing radiation at all in the near future. So the other question is, how can we image more efficiently and faster? As well as doing quantitative imaging, we want to be able to actually get this information in a time-efficient fashion, and I think this is where deep learning is going to really shine. We're already seeing that diffusion MRI can be hugely accelerated with deep learning. This is some really great work, I think, which has been done by Matthew Blackledger's group at the Marsden. So normally when we do diffusion imaging, we have to acquire a whole series of images, and we actually average them out to sort of get rid of the noise in the image, because the actual signal-to-noise ratio of these images is very low. And this is what we do. Our standard imaging is, you can see here on the right, so we've basically acquired the image 9 times and taken an average. But what he has achieved here is to only acquire the image 1 time and then use an AI algorithm to essentially denoise the image, and you can see that those images are very similar to the standard scans, but in a fraction of the time. So we can actually get a whole body diffusion MRI scan in about 5 minutes, which I think is really revolutionary, and most places are taking 30 or 40 minutes to get these scans in standard practice at the moment. It's also worth pointing out, I think, that the actual processing we want to do takes time. So if we want to do QMRI processing and separate these properties, we do need algorithms that do this, and those do take a long time. And deep learning can actually really speed this up. So this is a method that we've developed at UCL called RADAR, and it actually performs a particular form of QMRI processing about 500 times faster than conventional fitting. So rather than this taking probably an hour or 2 for a normal image slice, we can do this in a matter of seconds. So it's opening the door to much more flexible and powerful algorithms that we can just press a button on and get the information. So speeding up image acquisition doesn't say anything about how we can actually improve the image interpretation, and currently that's quite a subjective process which depends on the radiologist who's actually looking at the scan, but I think image analysis methods within the AI umbrella can really help with this. So there are a few early examples of this, although I think it's in an early stage. This is some nice work that was published in Investigative Radiology showing how a segmentation method can be used to identify areas in the ADC map which can then be, from which ADC measurements can actually be extracted, and that was shown to correlate very closely with expert annotations. But clearly, in a setting where we want to apply this across multiple hospitals, there's potential that this is going to make those measurements of tissue properties much more consistent, reproducible, and useful for clinical practice as well as trials, I think. And we can also use image analysis methods, some of which may be AI-based, to get objective assessments of disease burden. So this is a paper which is actually several years old now, but I think it's just starting to reach fruition, again from the Marsden, showing how we can measure changes in disease volume using diffusion MRI, and we can get quite precise and responsive measurements of disease burden in these patients. And they've recently got CE approval for a tool to do this in prostate cancer, and I'm told that there's a myeloma tool on the horizon soon. So just to summarize what I've said, I think with MRI in particular, there are three main areas where we can really do much better and where we're going to do much better in the next 25 years. And these are tissue characterization, efficiency and speed, and consistent image interpretation. So thank you to these people for contributing to the talk. And I think we do take questions at the end, so happy to discuss them. Thanks.